Dear colleagues, this is a hard cataract. You can see the dark brown appearance of the cataract indicating it is quite hard. Nuclear sclerosis may be grade 4 plus or grade 5. I have taken up this case for surgery. Let us watch the surgical steps. By this time I have made the main incision and two side ports. And now I am going to stain the anterior capsule with trypan blue dye. So I inject a big air bubble, and underneath the air bubble I inject the trypan blue dye. If I use the dye underneath the air bubble, the dye is not diluted and high concentration of the dye sticks to the anterior capsule, and you get a staining in a very short time, within 5-6 seconds. Now viscoelastic substance is injected. I am using SPMC. Viscoat should be used in such cases by beginner surgeons as well as by established surgeons. There was some ballooning of conjunctiva at the main incision, and it has been released. Now I'm going to raise a capsular flap with this 26 gauge bent needle, and I'm going almost along the border of the anterior capsule and getting a large rhexis. The diameter of this capsular rhexis will be about 6 millimeter. It is mandatory almost to get a large rhexis, to achieve a large rhexis in such hard cataracts. Now hydrodissection. At multiple points, a little bit of fluid is injected and the nucleus is depressed. So in this case I have injected fluid at 3-4 points, injecting some more fluid here, and I see that the nucleus is mobilized now. It is rotating freely. That's it. The nuclear rotation, hydrodissection should be very gentle in hard cataracts. There is no epinuclear cushion in such cases, and we have to be very careful in managing the nucleus. And now I'm going to introduce the tip of the Phaco handpiece, and I'm going to do direct chop in this case. And the technique which I frequently show is submarine chop. I go deep into the substance of the nucleus, bury the tip completely into the substance of the nucleus, and go near the opposite equator and then chop. That idea is I am at a deeper plane, and if I try to chop the nucleus going at a deeper plane, I will be able to chop it. Yes, I have been able to divide the nucleus into two heminuclei, and each heminucleus is being subdivided into two parts. So this is the other heminucleus. Go deep into the substance of the nucleus like a submarine and chop it. So now each big nuclear fragment is to be emulsified. So what I do is I start from the apex of each heminucleus, each quadrant. I tilt it, get the apex, and start emulsifying from there. See how I tilt it. Just with the chopper, I depress the anterior part and the posterior part like this. Depress the anterior part and the posterior part comes in front, and I start from the apex. I call it attack from the apex. Why? Because if the other side, equatorial side, rests on the posterior capsule, it will rest on a large area and there will be no pointed pressure, so the posterior capsule will not get ruptured by these fragments itself. Phaco power used in this case was 90%, yes, 90, and flow rate was 45 ml per minute, and vacuum is 450 millimeter of mercury. And for the last fragment, I am using this instrument called PCP, posterior capsule protector. Since there is no epinuclear cushion, this instrument will not allow the posterior capsule to come near the aspirating port of the phaco tip. That's it. The nucleus has been managed. Dear colleagues, this is a totally unedited video. You are not going to miss anything. And this is a real-time surgery. And the surgery has been completed in 8.5 minutes. I don't encourage you to do fast surgery, but I encourage you to do safe surgery. Now, to protect the corneal endothelium, we must not fiddle in the anterior chamber with instruments. If you want to do safe surgery, you have to be very expert in managing the nucleus. Must be able to manage it quickly, safely, keeping an eye on everything. Vision should be, must develop some kind of intuition to protect each and every cell of the eye. And this is a hydrophilic acrylic intraocular lens being implanted under irrigating fluid. See how I implant the lens, the drilling haptic with the irrigating probe itself. I am placing it in the capsular bag. Since viscoelastic substance has not been used, so a lot of time that I spend in some cases, that time has been saved. Moxifloxacin has been injected. Now I hydrate the side ports to make these wounds watertight. Hydrate the side ports with BSS. Now some viscoelastic substance stick to the corneal endothelium. I go with the Simcoe cannula and gently direct a stream of BSS towards the corneal endothelium, and whatever visco that sticks to the, here it is, whatever visco that sticks to the corneal endothelium comes up. This doesn't cause any damage to the corneal endothelium. The fluid is injected very gently. The antechamber is formed and the case is concluded. Hope this video will help you in your practice. Thank you very much for your attention.